Okay, welcome everyone. It looks like folks have found their way here, which is terrific. My name is Sarah Switzer, and I am the CBR Canada's Program Coordinator and the moderator for today's session. Although for those of you who have attended CBRC events before, you'll know I certainly won't be doing the talking. Today's session is entitled Long-Term Care Homes During the Pandemic, Lessons Learned and Rethinking the Future, with our fantastic speakers, Chantal Trudel, and Soo Wong, who I will introduce shortly. This event is being recorded and closed captioning is enabled, and you can toggle it on at the top of your screen. Before we begin, I want to acknowledge that the CBR Canada Secretariat is situated on the traditional territories of the Neutral, Anishinaabe, and Haudenosaunee peoples. Many of you may be calling in from different locations across Turtle Island, and so I invite all of you to introduce yourself into chat, including where you're calling in from, or maybe the organization that you're with, where your feet are planted, the territories that you're on. When you introduce yourself, just make sure that you toggle to the chat to everyone, so not hosts and panelists, so we can get a sense of who's in the room. And if you don't know the territories that you're on, nativeland.ca can be an excellent resource. I am personally calling in from Tuckaronto, as covered by Treaty 13, and I'm so grateful to be here with all of you today. We have a real mix of folks in the audience today, which is such a delight. So today's session is the 6th part in our 8-part series on community-based research and COVID-19, addressing widening inequities and amplifying community-based visions for change. The pandemic has had us witness so much loss and grief and uncertainty and turmoil. And our long-term care staff and residents and family members and caregivers have seen so much of this struggle. During January's webinar, we learned from Elder Dr. Sean Haynes about what it means to pause as this form of kind of ethical relationality, as a commitment to thinking about ethics. And so with that, I actually want to start us off by asking us to all pause for a moment, just to acknowledge the lives lost in long-term care during this pandemic. One of the things we do in each of our CBR Canada webinars is we begin our events by reflecting on and amplifying the goals of the Truth and Reconciliation Commission's calls to action. In the spirit of reconciliation, CBR Canada is committed to engaging with and learning from diverse Indigenous peoples and communities across Canada, as well as addressing these TRC calls to action. And so this month, we're starting this particular webinar by highlighting Call to Action 21, and I'll read it out loud for folks that might be calling in and can't see the screen. We call upon the federal government to provide sustainable funding for existing and new Indigenous healing centers to address the physical, mental, emotional, and spiritual harms caused by residential schools, and to ensure that the funding of healing centers in Nunavut and Northwest Territories is a priority. Our speakers today will be talking about our long-term care system, funding, and policy challenges that end up structurally disadvantaging those who need support and care. And so we begin here with Action 21 to acknowledge the interconnectedness of these funding and policy challenges and their impacts on communities. Today, we will hear from our presenters via a formal presentation and followed by that a Q&A. Next week, on February 24th, during our live discussion, and I encourage you to all come out, we'll be turning the mic over to all of you and doing some work in breakout groups. And I hope that we can continue reflecting on these overlaps and interconnections with the TRC today and during upcoming events on the 24th, so we can keep advocacy front of mind. As our presenters will share, healthcare is political. For those of you who are new to CBRC, Community-Based Research Canada, Community-Based Research Canada is a membership-based organization whose mission is to advance community-based research excellence in Canada by strengthening partnerships, building capacity, mobilizing knowledge, and championing CBR amongst individuals, communities, and institutions. We are a social enterprise funded entirely by our members, and we have over 40 members at this point. And the Center for Community-Based Research is the CBR Secretariat, which operates the day-to-day activities of CBR Canada. As part of our programs, we host several events, including webinars and live discussions like today's and next week's. I'm going to ask Jessie, who's providing kind of tech support during the webinar today. So you can reach out to Jessie if you need, you have any questions at all, to pop the sign up link for our newsletter in chat, as well as the link to our upcoming discussion next week. Okay, and if you have any questions or issues throughout the webinar, he's your go-to. It can be hard when we're speaking to pay attention to the chat, but we'll do our best. And the newsletter is really for those of you listening after the fact. So if you're listening to the recording, because we are recording this, the newsletter is the best place to stay up to date for all of our events, including next week's discussion, as well as March events, which will focus on Indigenous-led approaches to youth housing. Okay, so let's get started. I have the pleasure of introducing our presenters today, Chantal Trudel and Soo Wong. I have truly appreciated conversations, Chantal and Soo and I, that we've had leading up to today about the interconnections between architectural design, policy change, community-based research, and the profound impacts of all of those things on those living and working in long-term care. No doubt we will be in for a very generative presentation today. So I'm going to introduce both of our speakers and then I will pass it on to them. Chantal Trudel is the inaugural director of Carleton University's Center for Community Engagement. She is the associate professor in the School of Industrial Design, a member of the Human-Computer Interaction Program, and cross-appointed to the School of Information Technology in the Faculty of Engineering and Design. She is an industrial designer, a human factors professional with an honors BA in philosophy. Chantal is a faculty member with the READI program at Carleton, funded by NSERC Create, which stands for Research and Education in Accessibility, Design, and Innovation. She is also currently developing the Abilities Living Laboratory at Carleton, a CFI-funded collaborative and community-facing laboratory space focused on supporting personal mobility, rehabilitation, as well as accessibility and inclusion in public life, which I'm sure we'll hear a little bit today through the work she's been doing in long-term care. Prior to working at Carleton University, she worked as a product designer, followed by more than 10 years of experience in healthcare planning and design. And she has been a strong proponent of participatory design, acting as a facilitator to engage community stakeholders in the design and development of their projects. Soo Wong was an MPP from 2011 to 2018. She is currently seeking election as the Liberal candidate for Scarborough-Agincourt in Toronto. Soo was the former executive director for a nonprofit long-term care home in the Greater Toronto area. She has lots of direct experience there. She has an extensive background in education and was a former TDSB trustee and nursing professor. She is also the founder of the Reading Circle, a program that promotes children's literacy in the community. So with that, I will pass it over to our speakers for today.
Thank you so much, Sarah, for that introduction. And it's an honor for me to be here today with Soo Wong. And I'd also like to thank members of the audience for joining us for this important discussion today and taking the time to listen to what we have to share. I'd like to acknowledge that Carleton University and my home are on the traditional and unceded territory of the Algonquin Nation before we start. If you could go to the next slide, please, Sarah. Since January 2021, our research team has been documenting the design of long-term care homes during the pandemic. And we did this to understand how residents, staff, and family members were being impacted by the pandemic. And specifically, we wanted to understand how the design of their homes influenced their quality of life and their ability to support infection prevention and control or what I will call IPAC throughout this presentation. I would like to thank Carleton University, the Foundation for Health Environments Research in the United States, the Canadian Institutes of Health Research, and the Ontario Centers for Learning, Research and Innovation in Long-Term Care for supporting this research. And it's important to note that the views presented here today do not necessarily reflect the official position of these organizations. This project received ethics clearance from the research boards of Bruce Bruyère Research Institute and Carleton University. Go to the next slide, please, Sarah. So today, this is a long list of research studies that our research team are doing in long-term care. And I just wanted to put this up there because this may be of interest to audience members. But today I'll be presenting the research project that's at the very top in yellow, COVID-19 design of long-term care homes, learning for the future. So we have a number of other long-term care research studies on the go. So if any of these are of interest to you, you would like more information, please do reach out to me. I'd be happy to talk to you about these projects and provide you with additional information. The next slide, please, Sarah. And importantly, I'd also like to draw your attention to the public review draft of the new CSA standard Z8004, Operations and Infection Prevention and Control for Long-Term Care Homes, which is now available. So this standard was developed by the CSA Group Technical Subcommittee on Long-Term Care Homes under the jurisdiction of the Technical Subcommittee on Healthcare Facilities, and I was a member of the committee. The draft is available now for a 60-day public review and comment period until April 11th, 2022, and the link has been put in the chat. I highly, highly encourage you to participate in the review of this standard. We are looking for comments from the community on the design of this standard and would love to hear from you. So if you could go to the next slide, Sarah, I'm going to talk about the rationale for the study. So systemic issues in long-term care were being researched prior to the pandemic by prominent researchers like Pat Armstrong and Susan Bradley in Canada. In the US, researchers like Aisha Gersis, a human factors specialist, and Morgan Katz, a physician. But the inadequacies of home design readily surfaced during the pandemic, underscoring the need to study the design of long-term care homes. So statistics, which I show here from on the slide from the Canadian Institute for Health Information, capture the devastating impact COVID-19 had on this sector. And I'm just going to read these quotes. So as of December 9th, 2021, in Canada, long-term care residents accounted for 3% of all COVID-19 cases and 43% of COVID-19 deaths. Between March 1st, 2020 and August 15th, 2021, over 56,000 residents and 22,000 staff in Canada's long-term care and retirement homes were infected with COVID-19, resulting in more than 14,000 deaths among staff and residents. So needless to say, these numbers are disturbing, and especially within the context of what is essentially supposed to be a home and a care setting. So this underlines the need that we need to pay more attention to the design of long-term care homes, but also other congregate living settings, such as assisted living for persons living with disabilities, retirement homes. These are also important settings to be studying. Documenting frontline information from homes not only provides the detailed examples that we need and evidence on how change is needed, but it can help us rethink the design of these homes. We want to mitigate the physical and psychosocial risks associated with significant infectious outbreaks like COVID-19, but not just COVID-19. We're also interested in common daily pathogens that are transmitted or seasonal infectious outbreaks. You could go to the next slide, please, Sarah. So the research objective was quite straightforward. We wanted to know what works well and not so well in long-term care homes within the context of the pandemic, but from the perspective of staff, residents, and their families. And I've put this quote up here by Ronald Mace, who's an architect, a person living with a disability. He's a product designer. He was an educator as well and a consultant, accessibility consultant. And he's best known for his advocacy work in accessible design and championing the building codes and standards in the United States to support accessible design. And it's Ronald's work and others who have supported this vision that really give me hope that other much needed changes in design to support our elders and persons living with disability will come to long-term care specifically, hence why I wanted to highlight the CSA standard. So when the pandemic was emerging, we saw this urgent need to capture this important period in our history. And we've been doing that with the active participation of staff, residents, and their families. We've been documenting the impact of home designs on daily living, but also infection prevention control. And some of the specific things we're looking at are what were the challenges related to the design of the home? How did that home need to be adapted? What innovations and participants, what did they bring to the table to innovate under these conditions? And what are some unmet needs and opportunities for change? What couldn't they address through their workarounds and adaptations? If you go to the next slide, please, Sarah. So we took a human factors, Sarah mentioned I'm a human factors specialist. We took a human factors approach to this project. And what that is we draw upon previous research and expertise from a number of different disciplines. And within the community of long-term care, we did that to design and implement this project. So for those of you who aren't familiar with this discipline, human factors studies are focused on documenting interactions, insights, and/or information as they relate to design development. So this might involve taking measurements, conducting observations, engaging in conversations with stakeholders on the front line and organizational stakeholders. Also trying to develop a better understanding of how people represent systems in their mind, how they think systems work. And we do this to design, it may be tools, it may be software, furniture, workplaces, or environments. And the ultimate goal is we want to improve processes, techniques, interactions, and communications to support human well-being and overall system performance. Next slide, please, Sarah. So this is a very important part of the presentation because I couldn't have done the study without working with homes to figure out how we were going to do this. So in the past, we would normally go on site. We would spend time in the community setting, whatever that might be. In my case, it's usually a clinical setting. And we would get to know the people we're working with prior to even conducting the study. We would spend time in the environment, we'd document, we'd start to understand how we were going to design the study with the people that we're researching with to support whatever initiative it is that's of importance to them. So at that point, we would design the study with them and then spend many hours observing, for example, their workflow or activities to understand how the design is impacting their ability to achieve their goals. But we could no longer work on site during the pandemic, which a number of researchers have had to find alternative ways to work in the community. And so this was a very delicate situation, especially considering homes were already overworked prior to the pandemic with the onset of COVID-19. They were inundated with new protocols. They were in a process of continual change, constantly in a state of adaptation, and they were reacting to all of these changes while trying to provide care and while trying to maintain, excuse me, lines of communication open with family and friends about the care of their residents. So at the beginning of the project, we were very fortunate to consult 2 homes, and they provided advice on the design of the study in a way that they felt could be manageable for homes to participate. So this involved having, instead of us going on site, it involved having 1 or 2 staff members document the homes through a photo diary and memos, and then following up with those staff members through a 1-hour interview, sometimes longer if they wanted to speak longer with our research team. We limited this activity specifically to 4 hours. We told them not to spend any more time than that because we respected their time. We knew it was very, very valuable to respect their time, considering the conditions that they were working under. And we compensated staff according to peer payment standards. In this case, we looked at CIHR standards, and BC Centre for Disease Control has good documents, guidelines on pay pyramid standards. And we also consulted with the homes to understand what was the best way to reach residents to find out about their experience during the pandemic related to the home design. And they had a number of suggestions. They supported staff helping residents with the technology if they needed it to meet with our research team, and that went really well. We also offered to speak to residents over the phone if that was a preferred medium for them. We also had family members involved in the study, and originally we were compensating them as well. We compensated the residents according to the peer payment standards, but also family members. But what we found is we had this outpouring of support from family members and who wanted to participate in the study, but we could only, with our limited funding, we could only fund one family member per home. So the family members asked us if we would change our ethics protocol so that they could participate without compensation. So they were advocates changing our protocol as well so that we could have increased participation from family members. So all of this was very touching, this outpouring of support from the homes to participate in this research, and we continue this dialogue with the homes, and we flex the design as needed of the study to respond to the emerging conditions of research. And one home, for example, suggested to us that we change our co-design sessions so that residents or family members could have their own session or individual session because they may feel more comfortable participating without staff present, for example, so that if they had negative comments that they wanted to discuss, they were free to do that and didn't feel pressured by having the staff members at the table. So unfortunately, since Omicron, we have had to put a pause on our study because there are a number of homes throughout the province, throughout Canada, are dealing with ongoing outbreaks. And when we return to working with the homes, we will again ask them how we need to change and adapt our study to respond to their needs and their wish and ability to participate. So you could go to the next slide, please, Sarah. So before I present a quick snapshot, it's going to be very quick because I have very little time with you today of what we found so far. I'd like to give you an overview of the study. So we worked with 9 long-term care homes in Ontario, 6 homes we've completed data collection, 3 others are still in progress. So of those, 6 were not for profit and 3 for profit. There have been 35 participants to date, with more in progress for the 3 remaining homes. That's 8 residents, 16 family members, and 11 staff. And I've listed the staff members here, and you can see there's a diversity of staff members that have participated, and they all had to have knowledge of infection prevention control as it relates to their profession. So we also had floor plans from all the homes, and we did floor plan analysis of their designs. And we wanted to understand their ability to physically distance in the design of their home. And we also did wheelchair planning studies to assess crowding due to mobility equipment. And the homes have a lot of equipment beyond wheelchairs, which are the personal equipment of residents. They have mobility lifts, carts, and a number of pieces of equipment in the homes. So this was an important study for us to do. We've conducted qualitative analysis on the self-reports from the home, self-reports meaning the photo diaries, the memos, and the interviews, using In Vivo, which is a qualitative analysis software. And we've done this so far on the first 6 homes. So the data I'm going to show you today is from the 6 homes. So of those 6 homes and the staff photo diaries, we collected 457 images documenting factors related to home design. And of the interviews and focus groups with residents, staff, and family members, we have over 200,000 words or 400 single-spaced pages of data. That's a lot of data. So we are slowly processing this data. As you can imagine, it takes time. If you could go to the next slide, please. So here's just to give you, we've done an illustration of the characteristics of each home, and I just wanted to show you one here. And it's an example of a home profile. So some of the things to note in terms of who's affected, right, by the design of homes are the distribution, gender distribution of residents. So in this case, it's 85% identifying as female, average age, 82.7 years, length of stay is over 461 days or around 15 months. The number and gender of staff you can see is mostly female. We have staff distribution, the services offers and amenities listed here. But one thing collected, which the homes were interested that we were collecting this, was that we collected how many residents use wheelchairs. And you can see how high this is in home one, and it's high for all the homes we collected. In this case, it's 65 to 75% of residents. And this is really important because it impacts space planning, crowding, and contact with high-touch surfaces. So in the early days of COVID-19, we didn't know whether COVID was transmitted by contact surfaces. And so it is important to study environments in terms of high-touch surfaces. Now, we know that COVID is airborne, transmitted airborne. But in this case, it's important to design the homes for the future for contact transmission. So in the case of influenza, for example, or gastroenteritis, which are common high-risk pathogens in homes. If you could go to the next slide, Sarah. And we did a number of planning studies, and I'm going to just quickly show you these so you get a sense of physical distancing and crowding. So the green bubble shows 2-meter distancing, what's needed, that's space. The blue bubble shows the Ontario Building Code and National Building Code minimum requirement for a wheelchair turning radius. And the pink or purplish bubble shows the minimum requirement for a bariatric wheelchair for persons living with obesity. If you could go to the next slide. So if you see in a single resident room, this is one of the rooms, what it would be like to physically distance in these rooms and how maneuvering with a wheelchair, how someone would do that in the room. You can see how crowded it is. And if you go to the next one, I'm showing a double room. In the double room, you can see, again, the risks associated with physical distancing in a shared room, and again, the lack of clearances for someone in a mobility device to maneuver through the room. If you go to the next planning study. This is a planning study for a person of size, person living with obesity, and you can see how inadequate these room designs would be: a resident room, a single room, a double room, and the public washrooms. Not only is this a human rights issue, but it's a contact infection prevention control issue for contact transmission pathogens. We go to the next slide. Here's a dining room study. And again, you can see how the design of this dining room limits the number of people who can be seated in this space, and also the circulations. And we did hear from homes that the wheelchairs and the sheer number of them in these environments poses risks to residents because it's difficult for staff to quickly get to a resident if they happen to be choking because of all the congestion. We know that they had to take over other rooms, activity rooms. Residents had to eat in hallways, in single lines to spread people out for safety. And this reduced the amount of supervision that could happen for the residents. So again, high risk factors related to infection prevention control. If you go to the next slide. The last one here I want to show you. So again, we did 53 of these studies. This shows you one single shared staff area, and you can see how congested it is, a computer room and a nurse care station. We did want to point out, again, the staff worker areas are also very, very important for physical distancing, and homes had to come up with a number of tactics to spread their staff out. If you go to the next slide, Sarah. We also did a number of scenarios that show what the homes went through, and here's some quick examples. So excessive signage, there was signage fatigue, so homes were continually changing signage because people would start ignoring signage. Partitions were built in the double rooms. PPE storage, they didn't have adequate space for the massive PPE storage and the garbage waste cans that they needed to dispose of PPE waste. And if you go to the next scenario, you'll see here, I wanted to include this one. This is very important. So this was a story from a person, participant around living with obesity in the home. And you can see the number of constraints the resident would face, not being able to sit at a table, not being able to pick up their clothes. So think of all the staff shortages during the pandemic and their inability to provide care, right? Staff off sick. The more we can build these environments to be independent, residents to be independent, we will be responding to operational issues as well that are a result of infectious outbreaks. So design for infection prevention control goes beyond what we may typically think of design for infection prevention control to factors such as resident independence. If you go to the next slide, please, Sarah. And I'm just going to read to you, I'm not going to read all of these quotes, and these will be available on CBR Canada, but these are data points. These are details provided from our participants. So you can see on the left, the quotes from the residents talking about the single rooms. So as far as I'm concerned, for poor sanitation and for social reasons, I think all long-term care homes should have everybody have their own room and their own bathroom. The participant above talks about the lack of space in their room. And we had a family member talking about going outside and how difficult that was for their mother because originally they were in a walker, and then in a wheelchair, how difficult it was for them to go outside. And that was the only place that they could visit. So we need to pay attention to how we access the outdoors to provide safe visitation under those considerations. The next slide. These are about staff spaces. So you can see on the left, there's a soiled room that's next to a staff room. And so staff are congested around a soiled area. The locker rooms, how congested they are with PPE storage. And one home bought an RV to safely spread staff out throughout the home. Next slide. So these details are not the details, they make the design. So this is why it's really important that we pay attention to these details. And I wanted to put up this quote from Charles Aim, an industrial designer, because I really think this is what it comes down to, is addressing these details. Next slide, Sarah. And just to tell you, share how much data we have. So these are the categories that, these data points have been put into, and now we're packaging this for the homes. But you can just see how many times, 400 coded reference, 400 times was participants mentioned the emotional aspects of the home, the shared spaces, the issues with shared spaces, the issues with residence room. 300 times they mentioned additional precautions, cleaning and disinfection, over 300 times, and over 200 times things like storage, the entrance and exit areas, the shared staff spaces, again, outdoor areas, the hallways. So this points to specific areas that designers need to pay attention to, and we'll be unpacking that in more detail in publications and for our homes. Next slide. And so the next steps is we're doing design studies with the homes. And this is an example here of just a blocking study. Once Omicron, the homes are in a better state to participate again, we'll be circling back with this information and design studies. And I'd like to end with this quote from Michael Graves, an architect who had a spinal cord infection and became an advocate for disability and accessible design to serve persons with disabilities. And he believed that well-designed spaces and objects can actually improve healing, while poor design can inhibit it. And Michael Graves dedicated himself to this. And we need to have this mindset in terms of long-term care. So thank you very much. I'm going to hand it over to Sue now, who has the larger picture on long-term care design and policy and programming. Sue?
Sorry. Thank you very much, Chantal. And thank you, Sarah, and everybody from CBRC. I'm very pleased to join Chantal to do this presentation today. Can you go to the next slide for me, Sarah? So the COVID-19 pandemic started as early as, I would say, February, March 2020. The data from British Columbia, when they had the first death in Canada related to COVID-19 in January 2020, that triggers across Canada, we should be worried. So the knowledge and experience from the management team is critical when it comes to dealing with the pandemic. What Sarah's introduction about my bio, I have a public health background. I was involved with the SARS. So some of you remember back in early 2000, 2003, there was a SARS. I was in York region building up the SARS clinic. So my background in public health absolutely helped me in long-term care management dealing with the pandemic. So the knowledge and experience comes in when you're dealing with this pandemic. Particularly, you have to be proactive. Proactive in terms of your knowledge, proactive in terms of your experience, because for a long time, executive director or administrator for long-term care, not familiar with public health or understanding the outbreak and they're used to managing influenza, GI outbreak, that kind of stuff. When you're dealing with a virus like COVID-19, you got to be proactive from ordering the supplies, because very early in the pandemic, phase 1, there was already challenges dealing with ordering the PPE. So knowledge and experience dealing with pandemic is critical. Communication starting from your leadership team, because every long-term care home, there is a leadership team, and then going all the way down to the frontline staff. I was working in a not-for-profit home, so I had to deal with my board of directors. So communication is from internal and external. So when I say internal, I'm talking about the leadership team, I'm talking about frontline staff. Every week we had communication about COVID-19. Every week during the first and second and third wave, I was meeting with the family council as well as the residents council to communicate with them about the pandemic, because people were very afraid, especially during the first and second wave. There was so much uncertainty with the communications from the ministry and the minister. So communication is critical during the pandemic. And you also have to communicate to external partners. When I talk about external partners, I'm talking about our physical therapists, we are contracted services when it comes to housekeeping, dietary services, and what have you. So communication is critical because you lessen the anxiety, the stress, and fear, because family now are afraid what's going on with their loved one. And then communication also dealing with visitation, because no longer our family and family or the friends can come into the home for visits. So we did a lot of window visits. We did a lot of FaceTime, Zoom meetings, and then some. So technology became a different way to communicate with everybody around the home. When I talk about the minister and ministry of long-term care, as well as public health directives, these directives comes during the first and second and even the third wave was so regular that, you just been introduced one directive, 2 days later, there's a new directive comes in. So you need to be on top of these directives, but you also need to understand and communicate these directives to the staff, to all our family members, and as well as the external partners. So when I say minister's directive, just to give you an example, right now across long-term care, we are required to have booster. The minister had delayed the booster boosters information, how long the directive is, but it's very, very important you understand how to implement. Can we go to the next slide, please? The lesson learned from the pandemic, as I said earlier, got to be proactive and communicate that directive quickly to everybody, and it has to be comprehensive and being transparent. Transparent to educate your staff. We have weekly training, weekly information to families as well as the volunteers, and we do daily audits. Daily audit from my level as the executive director to frontline housekeeping staff, to frontline PSW, and managing outbreaks is challenging, is exhausting, but most importantly, you need to support staff because there's a lot of anxiety, a lot of fear. And when I talk about recognition for staff, we had a lot of coffee cards given away, even gas cards. There were times that we were doing high tea when we can, having food brought in from the community. What we learned during the pandemic is that there need to be 180 transformation when it comes to long-term care. It's not just about the ventilation. During the first, second, and third wave, the ministry focused a lot on ventilation and PPE. What I learned throughout the pandemic was the fact that there needs to be 180. Funding is a challenge, staffing and design of the long-term care. Future long-term care, working with Chantal and her team, provides that new education, what long-term care should be like, because this is somebody's home. This is not just a healthcare facility for seniors or adults with disabilities. And last but not least, yes, you can go forward to the next slide, Sarah. I want to share with all of you this particular design manual that was that's currently still in operation. There's some conversation right now as I'm speaking to you that there may be some changes to the design manual. But when I last spoke to the ADM about this particular file, I heard it's not being changed. But whatever it may be, this design manual needs to be improved to reflect the pandemic issues, but more importantly, to address some of the data that Chantal and her team have identified, especially when the ministry right now making new bed announcement. And I'm going to end with the last slide. Sarah, can you move that one? That last slide is the fact that when we're dealing with healthcare and health policy, it is political driven, and healthcare is political. And as we can see right now, as we speak, we are on the 4th or 5th wave of the pandemic. And we cannot say that healthcare is not political when decisions are made at Queen's Park, and the fact that healthcare should be evidence-based, but at the same time, we know that the policy is driven by the ministry and the minister. So I think I'm going to stop right now, Sarah, because I know there's a time limit. And people can follow up with Chantal, myself, and our email address.
Fabulous. Thank you so much, Sue and Chantal. That was tremendous. So, wow, I'm sitting with so much that you shared here. We are going to move on to questions. So I'm going to stop sharing my screen so we can see folks. So just a moment as we technologically transition. Okay, and I'm gonna bring, just a moment, folks, I'm gonna bring Sue and Chantal up onto the screen here. There we go. Wow, what a brilliant presentation. Thank you. The numbers that you shared, Chantal, at the beginning, I was writing them down like, oh my goodness, like what an impact. 56,000 residences, 22,000 staff, 14,000 deaths, like those numbers hit home. They're powerful. Sue, what you shared, this is somebody's home. This is somebody's home. Wow. Thank you so much, both of you, for your presentation. We have about 10 to 12 minutes left for questions for folks, and just in case you can't see me, here we go. So the way questions work, if you notice, if you're in the audience, there's a small Q&A toggle button. It kind of looks like a chat at the bottom. If you click it, you can type your questions into the question box, and we will, I'll share them with our presenters. So I'll let folks do that now. Just give you a moment. And while folks are thinking about questions, perhaps I will start with a question to both of you, Chantal and Sue. There is such a mix of folks in the audience today, which is brilliant. This is what we love at CBR Canada events. We've got community-based researchers, we've got caregivers, we've got seniors, we've got folks working in the long-term care home sector, folks doing kind of advocacy work. And so given the diversity of folks in the space in our Zoom room, I'm curious, how do folks take away what you shared today? What are kind of next steps?
Sue, I'll let you.
I'm going to start. Today is actually 15 weeks till the provincial election. June the 2nd is the official provincial election. If they're long-term care advocate, they're long-term care staff right now on this webinar, I cannot stress enough for each one of you to follow up either with myself or talking to your local MPP or to the candidate. This is the time to influence the long-term care design, but more importantly, to find out from each of the 4 political parties to ask them, what is your platform when it comes to long-term care design? Because if you are not going to hear that platform right now during the election, then you're going to miss that opportunity. We anticipate there will be a provincial budget being tabled by the end of March. That's another place. This is a sitting government, majority government. It is another opportunity for you to have an influence on the platform for the provincial government because their budget should talk something about long-term care. I would be very surprised.
Thanks, Sue. Chantal, did you have anything to add to that? Or I've got a few questions that have come in. I can also.
Yeah, the ask has to happen, right? That's what we need is the ask. And my biggest concern is I know the funding differences between acute care design and long-term care design, and they're significant. And we cannot support these environments with the funding that long-term care gets in home design. It's not, the homes aren't able to do it. So that has to change as well.
Thank you so much, Chantal and Sue. And just a plug for our next session, in case folks do have to jump off early, our live discussion is very interactive and we'll be discussing all of these issues together and in terms of the key advocacy pieces. So ensure you come out, and maybe Jesse can pop the link in the chat for folks that do have to sign off right at 1. So we've got a number of questions, which is terrific. They've all come in at once. So from Kathy, I'll read this out. Although still early days, how might the research by Chantal and team potentially influence the future and forward thinking in the design of traditional institutional environments, particularly for vulnerable communities?
I'll take that one, Sue. As I mentioned, I think the details are really important to tease out. I think if we get at some of the details that participants talk about, it can make a world of difference. And so this is really our job now. The data set, as I mentioned, I wanted to show you, is very large, larger than I anticipated, but that's good because we have a lot of information to work with now, right? This is real life. And so we've documented it and we have this historical record now. So we can base decisions, we can base initiatives off of evidence. And Again, there's some lessons to take from acute care, right? So with SARS, there were some changes made in there, but it is a different environment. It is a home environment. There are challenges with designing for infection prevention control in long-term care. We don't want it to be a clinical environment, but I truly believe there's ways to do that you know, we're seeing in new designs that can keep it home-based. I think one of the most important thing that's come from all this, and we saw it in the greenhouse model designs that had a lower rate of infection, is the smaller cohorts of residents in households, right? We know this, we've been told not to go into large settings because of the transmission of COVID-19. So why are we housing residents in, you know, 32 bed units? It should be smaller cohorts. You could cohort the residents into 12, 15 units, and then you cohort staff with them as well. And so that's how you maintain control over infectious outbreaks. And it's more intimate, it's a residential setting. So it all makes sense. We just need the initiative to go forward with that mindset.
Thanks so much, Chantal. And I've got a question for the audience, because I see in chat that some folks are not seeing Chantal. And so I'm curious if folks can just type into the chat, can you see all three of us? Sometimes the webinar function is a bit strange. I can see all three of us. Oh, yes, fabulous. It looks like everyone can. So if you can't see the speakers and you're struggling a little bit, sometimes you have to go up to the top of your screen and click speaker view or gallery view. That might reset things. All right, and there was a comment while you were answering, Chantal, from Kathy. Great job, Chantal and Sue. So glad people are stepping in and using research to inform evidence for design. All right, so there's another question I have for both of you, and I'll read this out. This is from someone who is anonymous. As my parents age, I am worried of the state of long-term care homes when they need to rely on them to have positive quality of life. After seeing how little support the homes receive in such situations, do you have hope for their future?
Okay, I always believe there is hope, okay? But you have to be a strong advocate, starting with visiting the home on a regular basis, put a face to the home. I would take different times of the day when you do visits. Not every day at 2 in the afternoon. I would take meal time, like lunchtime or supper time, to see how the home operates. I will make sure care conferences are attended. I would, during the pandemic, because we already did so many different waves of the pandemic, I would say throughout the pandemic, each home should be using technology for visits. There's no excuse, okay? And I would document. Documentations to the home, to family councils, to residence council, if your loved one can speak for himself or herself. But I also would advocate the fact that if you have issues, you're the best advocate for your loved one at home. But I would also, during this time at the provincial election, is so critical for those of you who are from Ontario. This is your time to speak out. You cannot be silenced, okay? Silence means, where I come from, silence means you are okay with the current government's funding, current government's acceptance of the 2015 design manual, okay? If you don't speak out on behalf of your loved ones, someday, one of us in this panel or the entire webinar participant may need our long-term care. Okay, so we are advocating not just for ourselves now, but also for the future. So I always believe in hope. So I hope I answered that question.
Thank you so much, Sue. So we have time for one more question. I just want to recognize that we actually have more questions than we have time to respond to, which for me as a moderator is delightful. So I'm so pleased we have a lot of questions, but I am sorry we won't be able to get to them all. I will compile them all and share them with our speakers, and perhaps they can kind of respond via email, or alternatively, another plug for our event next week. Please come out. We'll send it out to all registrants because it will be a full hour and 15 minutes of essentially discussion. So today's session question is just the start. All right, so this question is from Monique. Great presentation. What I've learned as a 60+ caregiver is the communication has been filtered. In other words, as a need to know basis. I've been challenging this as not all caregivers are 80+ years old. Design of homes should be enticing to make it more comfortable for people to visit. I see some head nods here from our presenters. Many residents never see family even prior to COVID. So are you looking at the design to make people want to visit? Residents are 19 years old and up, not all seniors. Thanks, Monique, for that question.
Yes, and Monique, I'm really glad you brought up age, because that's another factor that's very interesting in terms of the design of the homes and to make them age appropriate. You can imagine too the social connections, how important that is, and so forth. So there are a number of challenges, and in human factors, there's competing constraints, right? It's what we talk about, balance and competing constraints, and looking at the variety, the diversity of people we're serving in long-term care. That's why I kept talking about persons with disabilities, because people tend to think of long-term care and they think seniors, right? But it's not just seniors. And so we really have to have that front of mind that there's young people in long-term care. Again, persons living with obesity, I wanted to bring that to the forefront because it's not talked about a lot, and it was talked a lot about in the data, actually. So I'm really glad you brought that up. And the visitation of the home, yes, of course, like we want to make it comfortable and encouraging, people to want to spend time. It's important for, the mental and physical well-being of the residents, of course, to have visitation. But also the staff, right, to have that support from family and that triad, right, working together in the home. So yeah, it's so much design change could take back. That's why I'm very excited about the CSA standard, because that's a start. And so again, it's a start, and I hope that's going to lead to some significant changes in long-term care design.
I also think this echo what Chantal said, that the proposal from the CSA standard will also mean that we need funding. Okay, it cannot do the new rebuild because there are many long-term care home, what I call D facilities, okay, or even B facility, B as in Bob facilities. You need funding. And this is what the challenge right now, right across the board in long-term care. Just the design itself is a challenge because the space, because you need land to build. Just think about, I'm from Toronto. Finding land in Toronto is difficult, but even rural Ontario, finding lands is difficult. So I think at the end of the day, this conversation is long-term conversation, but the proposal from the CSA helps the conversation. But we definitely need funding, both levels of government, federally and provincially, to address these issues.
Thank you so much, both of you. And thank you to everyone for your questions. I'm sorry we haven't had a chance to address them all today. What I will do, I'm going to read the questions out, if that's okay with folks, just so that we can have those questions in the air to keep us dialoguing about long-term cares and these important issues. So Claire asked, I work with post-secondary nursing students who cycle through clinical rotations and long-term care. Do you have suggestions for empowering them to advocate for change in these facilities as future workers? Terrific question. Thank you, Claire. Kidong asked, Ontario has announced new long-term care beds with guidelines for submitting proposals. Interested in how organizations approach this. Another question, for new NFP organizations interested in building new NTC homes, how do we get started? Terrific question again, Kidam, thank you. And an anonymous attendee asked, do you have any short or long-term goals with regard to your research? So I'm aware we don't have time to answer all those questions, but I'm putting them out into the universe and to thank folks for asking them and to say that we absolutely will have time to address them next week. So please come out. I see Jesse has already posted the link in the chat. And if folks can bear with me for just 2 minutes, I know we're almost at time here. I've got some slides to share with folks as we wrap up. Right. Just a moment. The transition is always a bit fun. There we go. So please come up to our upcoming live event. For those of you who haven't attended these events, they really are terrific. They are such, the best events are when we have so many different folks with different roles, folks with lived experience, seniors, caregivers, people navigating the LTC system, folks with disabilities, as well as community-based researchers, policymakers, funders, everyone in the room. We also know that those roles overlap in lots of different ways. So please come out to the live discussion. It'll be a great event. These discussions are often very advocacy and action oriented. For those of you who know folks who couldn't attend or want to access the recording or send it out to folks, it will be, it's being recorded and we'll post it online and we'll share it with folks very shortly. And let us know if you have any feedback on today's event. We're always learning and growing, and our events are very much driven by our members. So we take the feedback very seriously and they help us plan future events. So with that, I want to thank all of you for coming out, and thank you so much, Sue and Chantal, for your terrific presentation. And I really look forward to continuing it next week. So we'll see folks soon, and have a good rest of your afternoon or morning, depending on where you're calling in from.